Okay, so what I'm going to talk about now is. Yeah, I think I did.
No, it's county number.
Yay! Okay, so what I'm going to talk about now is the NICU. And I broke it down into different ways babies can come to the NICU for care. Now, what happens is that as NICU nurses, we watch the tracking shell that labor and delivery puts on the computer, and we have a list of things that we watch for, and this is that list. This is directly made from the American Academy of Pediatrics and the NRP group for kids that possibly could get into trouble that we want to keep an eye on. So maternal diabetes, we're going to talk a little bit more about that, but things like maternal infection, if the mom is very, very sick, you know the baby's going to be sick. Premature rupture of membranes, the GBS positive mom, if she ruptures her membranes, we're going to watch that baby a little bit more closely. Substance abuse, no prenatal care, those are all red flags to us that nobody's had hands-on this mom and baby, so we want to first. So these are all things that may not pan out at all. 35-year-old women are having babies all the time now, but every once in a while you're going to get a mom that is 36 and she's got hypertension and she's going into renal problems, so those kids are a little bit sicker than the normal newborn. Now, what can happen intrapartum during the delivery are emergency C-sections, any kind of forceps or vacuum-assisted delivery, pre-sip deliveries. The mom is just there as an antepartum to be watched for her premature labor, and she cries out, "I feel a little funny," and she's delivered her baby unassisted, so we need to jump on that baby. If they do a fetal monitoring strip and notice that the fetal heart rate is not normal. Moms that get general anesthesia, those kids are depressed. They don't want to breathe. So those are all reasons for delivery that we're going to jump on the baby and assist them. Postpartum factors, babies that have persistent low APGARs. We will accept a low APGAR at 1 minute. That's the baby that comes deer in the headlight look. You know, they really are in shock as to what's happened to them. So we'll accept a low 1 minute APGAR. But what we're looking for is that as it transitions, so through life, first couple minutes of life, we want those APGARs to improve. So we'll take a 3 or 4 at 1 minute, but we want a 6 or 7 at 3 minutes, something else higher at 7 minutes. By 10 minutes, it should be close to a 9 or 10. The kids that stay at 3, then you get a 4, then you maybe get a 3. By then, the NICU team is on board, and you're not even counting anymore because you know that baby's depressed and needs help. Any baby that's got any kind of resuscitation. Now, we don't consider a labor and delivery nurse or baby triage nurse. Yep.
I'm sorry, I'm going to interrupt, but we have a different PowerPoint.
Oh, you do you?
Yeah.
It's like, it's similar but not the same, yeah.
Oh, you've got the very old one.
It's the one that's on there right now.
Yeah, it's going to be similar.
Maybe somebody could upload this one for us.
Yep, I already told them I'm going to send them. So
Okay,
I'll
good.
send them both.
I think there's sorry.
Yeah, that's okay. But I will send this out. Okay, resuscitation. We don't mind a mother-baby nurse or a labor and delivery nurse giving a few puffs with the ambu bag to get the baby started. Those kids are usually a little bit respiratory depressed. And the number one reason kids don't want to have a high heart rate is because they're not breathing. So if you give them a few breaths, their heart rate's going to come up and their tone's going to come up. The kids that don't do that. All right, so out on labor and out of mother-baby, we've already talked about all of these assessments that you're done out on mother-baby in the previous PowerPoint. But if you notice any changes in what you've been seeing, so a baby is nice and calm and eats well and does well for the first day, but on the second day drops his temperature, doesn't want to eat, kind of lethargic, kind of pale looking, I would start thinking sepsis. I mean, that's pretty much the work that you're going to do because the mom may have had something you didn't pick up on. And any baby who is less than 37 weeks comes to NICU. We don't like kids to sit out there and they're called late preterms. So they're kind of at the borderline, so we just want to watch them. Usually only keep them 24, 36 hours and send them out, but we want to make sure they get a good start. And what this doesn't say is any baby that's under 2 kilos comes to the NICU. That's a 4-pounder, and they have their own set of problems for being a 4.4 pounder. Okay, the first category of reasons they come to NICU is prematurity. That's what I'm going to tackle first. The rate of prematurity is about 10 to 12% of a delivery. So if you're at a major center, then you know that you're going to get about 10 to 12% of the deliveries as premature babies. Unfortunately, March of Dimes is doing their job. This 500,000 premature deliveries also includes all the reasons that we would expect a premature baby. So moms that are IVF, they're going to give us a premature baby. Multiples, because you're going to have IVF, you're going to have multiple gestations, so those are going to be IVF. This 500,000 is from a few years ago, and that's just from babies being born. But now we're honing in on why they're premature babies. The March of Dimes is doing their job because most of our premature babies, instead of being 27, 28 weekers like they used to be, are now 32 weekers. Moms are staying pregnant longer, which is perfect. We want them to stay pregnant. So the bigger, more mature premature baby are much easier to take care of. The risk factors are, we've already mentioned IVF, cervical incompetence, any kind of placenta or uterine abnormalities, trauma, and advanced maternal illness. Moms are sicker than they used to be. They're not taking care of themselves before pregnancy. They may be a little older, have a more sedentary lifestyle than they did in their 20s. So that's all contributing to their illness as a pregnant mom. Now, the survival rate of a 24-weeker is up to 40 to 60%. We're doing great things. Technology is doing a wonderful job helping us keep these kids alive. We now have 1.0 French PICC lines, that kind of thing. And we have a 24-weeker in the unit now that weighed 800 grams. We thought that was big for a 24-weeker, but he's doing very well. But he's got the tiniest of everything going for him. Unfortunately, we're saving these little kids with better technology, but the morbidities haven't caught up with us. They're still out there that we fight. The rates haven't changed. These kids are going to have developmental delays. They're going to have CP possibly, mental retardation, learning disabilities. So it's kind of like you have to weigh the stress on the family for the rest of their lives with saving these 23, 24 weekers. So the baby has to demonstrate to us that a 24 weeker is going to fight with us, that we take head ultrasounds and follow their brain. Do they have any bleeds in the brain? If a 24 weeker has a positive head ultrasound, is it a grade 3 or grade 4? You let the parents know. So they have a better idea of what kind of life their life is going to be. So if it ever came down to making a decision of continuing, like the baby started coding and not doing well, renal shutdowns, they would make the decision to stop. The 24-weeker that we have in there now is doing very well. He's a fighter. He's already had 3 chest tubes, and he's had 2 ultrasounds of his head, and they're normal, but he's constantly in motion, just constantly. So we think he's going to do just fine. Okay, complications are directly related to how premature they are. You wouldn't expect a 35-weeker to have the same complications that you expect a 25-weeker. There's 10 weeks of development difference. So the smaller kids are going to have higher incidence of RDS, they're going to be on a ventilator, they're going to be on CPAP and BiPAP, and they're going to be there longer. 35-weeker might not need oxygen at all. They're going to come out screaming, just be small and puny. Thermoregulation, you would certainly expect a smaller baby to have more cold stress episodes. They have decreased fat stores, large body surface, decreased muscle mass, so they don't have what it takes in a 25-weeker to stay warm and get warm than a 35-weeker. They may be in an isolette for a day or two, but as soon as they start maturing a little bit, we'll start trying them in a crib to see how they do. The babies that are born 25, 26 weeks missed that last trimester in mom, so they're missing the immunoglobulins that she was passing along to them. They missed that protection to help decrease the infection rate. So these guys here are very susceptible to infection, and an older child wouldn't be. The GI tract is much different in these two kids. Anatomically, the GI tract is developed at 20 to 22 weeks. It's a solid tube, just solid. Unfortunately, it's not supposed to be used yet. So peristalsis doesn't develop until they're 28 to 30 weeks. So this 25-weeker that we have has this tube, but it's just sitting there. Now, in utero, to help develop peristalsis, they would be taking tiny sips of amniotic fluid to help stimulate the gut. You need to develop the gut and teach the gut how to push the fluid and food through. So they're missing that. What we've learned in the last several years is we've started trophic feedings. A lot of research has been done on how to stimulate a baby's gut. And we do what's called trophic feeds. We put down a feeding tube into the belly, and we may pump maybe 1 or 2 mLs over 3 or 4 hours into the baby. We just drip it into so we're simulating the tiny little sips that this baby would have been taking. And by doing that, we're stimulating the gut to continue developing. We want that baby to continue to develop its gut so that when we want to feed the baby higher amounts, it's able to tolerate it. Coordination of suck, swallow, and breathing, that's even later, 33 to 36 weeks. So if you have a 35-weeker, he's in the window, but he may not want to perform until he's 36, 37 weeks. So which is very frustrating to families because they see this cute little package that has a feeding tube, and that's the only reason he's in the hospital. He just won't eat. He stays warm, he doesn't have apnea bradycardia, he's not septic, he just won't eat. Developmentally, he's not supposed to be eating, and that's real hard to keep the family. The neuromuscular system, they have a very immature control of their vital functions. The smaller babies, they totally forget to breathe. And when they stop breathing, because they don't remember the brain stem is back here, and it isn't fully developed. They haven't gotten that part. So they stop breathing because I'm done. I don't want to do it anymore. Well, when they do that, their heart rate drops. So then they're just laying there with hardly any heart rate and no breathing. We have to step in and start stimulating them. There's medications that do that. Caffeine, there's a form of caffeine, either IV or PO, very similar to what you guys drink in your coffee and your teas and your sodas. That helps the baby remember to breathe. They have a higher risk of intraventricular hemorrhages, those little bleeds in the brain. We have come a long way with that. In the old days, we would turn the babies to help suction and drain extra fluid out of their lungs. We turned them in Trendelenburg position. Now, what we didn't know at the time is when we were doing that, we were increasing pressure in the brain, causing little microbleeds, because the pressure would rise in the head like being hung upside down, that kind of thing. Your head hurts. So we don't do that anymore. We kind of keep them midline. We have what's called a tortal, and these kids are kept midline the first 7 days of their life to keep their brains kind of in an equilibrium that's very close to being in utero. And then we do serial head x-ray or head ultrasounds to check their brains. They have poor tone, weak reflexes, no cry. They essentially just lay there and make a face and let you guess what's going on. They're at a very high risk for dehydration. They don't concentrate their urine. So we follow urine out and fluids in, and it has to match almost exactly. These kids become dehydrated. If you lose an IV, and you can't get any fluids, and then they'll stop peeing. They don't have any excess to give you. We weigh diapers. We want to measure every diaper that comes off that baby to get the urine. Their blood is not in rare supply, let's call it. They don't have a lot of blood. So unfortunately, our lab machines haven't caught up with us, and they don't have the small bullets for NICU. They haven't made them yet. I'm hoping technology catches up in the lab. So what we've had to do is cut back on the amount of labs that we do with pulse oximeters. Have you seen those? I'm sure you guys have seen the little thing, the ET thing on the fingers. Okay, so we have those, and they wrap around the hand or the foot, and we now use that to follow the baby's oxygen. We used to draw blood and test it in a blood gas machine. So if we get good baselines, we just follow that to titrate the oxygen rather than continuing to draw blood off these kids by testing their blood glucoses or blood gases. We don't do bilirubins as much. We used to do serial bilirubins every 6 hours to make sure that they didn't get too jaundiced, and we're trying to protect their brain. So now what we do is called a TCB. It's a transcutaneous bilirubin that it's a machine that you just push on the sternum or the forehead, and it gives you a number, and that's their bilirubin that's in the skin. So we don't have to draw blood for that. So we've learned how to back down on the amount of blood that we do draw. The management for any of these kids that are sick is pretty much the same. You want to maintain an airway, you protect their respiratory system. Keep their saturations related to their gestation. If you're in labor and delivery, look and see on the warmers, there should be signs where the baby is placed, letting you know at what age, in minutes, should this baby's pulse ox be. Now, they probably don't use a pulse ox on every baby, because if it comes out pink and screaming, you can almost guarantee it's a good one. But if you have a baby in question, you put a pulse ox on them. Excuse me. We know that a brand new baby at 1 minute of age should only have a pulse ox in the 60s, mid-60s to 70s. In utero, that's what their pulse ox is. They're not 95 like we are walking around. They're in the 60s and 70s. So at 1 minute, we keep it at 60s and 70s. At 2 minutes, if we're controlling the amount of oxygen, we may crank it up a little bit to get the baby's oxygen a little higher. So we're titrating the oxygen up based on the baby, rather than insisting that the baby at 1 minute of age be just like us. So oxygen is a medication. It has free radicals, and it does affect the eyes, and we'll go over that shortly. Sepsis, you're watching for very subtle signs, apnea, bradycardia, color changes, little spits, little dips in temperature. The GI tract, we already talked about the trophic feeds that we do. We prefer the mother's milk, expressed breast milk. If for some reason she's not able to provide it, we do use donor milk. We get them to sign off on donor milk, and we do it by OG. Energy and stress. These kids burn calories with all of their exertion of energy. They're crying, their movement, bottle feeding. They're burning calories that we want them to keep on board and use to gain weight, to maintain their weight. They're only allowed to lose a few ounces. So what we do is we cluster care. We do everything we can in one block of time, and then we leave them alone up to 6 hours. This little kid that we have now, he goes 6 to 8 hours without anybody touching him. We take everything off the monitors. We take their temp off the bed because he has a probe on. The IV is infusing liquids. Diaper's good for 6 to 8 hours. We don't bother him. So he needs to sleep to grow, and we don't want to burn the calories by messing with him. As they get a little older, we start introducing some stimulation. These kids aren't mushrooms. They don't need to grow in the dark. So we may introduce mom's voice. You know, as she's going in to touch the baby, she may start talking softly to them. May introduce some skin to skin as they get a little more stable. This kid should go to skin, hopefully pretty soon, because it's been almost a week now that mom hasn't held him. Now this is a March of Dimes campaign. I just love this picture. It shows brain development. This is why we protect it so much. This is the brain of that baby that I keep talking about. See how nice and smooth it is? He has no pathways to process. He doesn't have any idea of what we're doing, so he's totally dependent on us. This is 5 weeks later, so if we could have kept her pregnant 5 more weeks, he would have been a little bit more mature. This is 3 weeks later. Look at the difference in the size and all the little crevices where all that energy and all that electrical stimulation is happening. This is a term baby. See the difference? If you can stay pregnant until you term, you're going to get almost a full-size brain that has all of the crevices and activity that it needs. This is you. Now, you as an adult will continue growing, and your crevices will continue to be active. And that's a good thing. Keep it stimulated. It's a muscle. It needs to be exercised, and that's why you're here, right? All right, complications. We talked a little bit about retinopathy of prematurity. It develops in about 84% of the preemies that get oxygen. We follow them very closely. We have a pediatric ophthalmologist that flies in, and he sees all the kids on a routine schedule every 2 weeks at Morton Plant, Countryside, and St. Joe's. And then he does all the laser surgeries that need to be done at St. Joe's. And then he just goes back to Miami. So he does this every 2 weeks for us. Babies that are less than 28 weeks, we've gotten so good at controlling the oxygen that only 80% of those 84% heal themselves. They reattach, they don't need laser surgery, their eyes are fine. And it's all vascular development. The little vessels find other pathways and everything is good. So we don't want the visual loss. What's too much oxygen? That's where the fine line comes in. Do you give the baby oxygen to treat baby? So if the baby is having trouble, do you keep cranking it up 100% to maintain 80%? You know that much oxygen is going to cause damage to the eyes. And you start having very serious conversations with the family right then so that they know what to expect. Now, NEC is necrotizing enterocolitis. This is a very progressive, rapidly progressing disease of the GI tract. Unfortunately, the kids that are less than 1,000 grams or less than 1,500 grams are the ones that we're going to expect to see it. And we've kind of taken the philosophy of expecting it and watching for it rather than letting it be a surprise to us. You don't see that much of it anymore with moms pumping and the use of donor milk. That is much better for the babies, and the babies are monitored more closely so that the NEC rate is dropped. Signs and symptoms are feeding intolerance. It could be a little spit here, a little spit there, abdominal distension. Kids that are admitted to the NICU automatically get an abdominal circumference. And if they're tube fed, we do an abdominal circumference every 6 to 8 hours just to maintain a nice number. We don't want any surprises. After their abdomen distends a little bit, you might see some bloody stools. They did a bowel x-ray. You might see some pneumatosis in the wall of the lining a little bit. And free air when it's perforated. I'll show you an x-ray of that. Treatment is NPO. You don't want to put food in this gut that's having difficulties. You put them on gastric suction, TPN, high antibiotics, and you take the baby to surgery. Our kids at Countryside are sent to St. Joe's for any kind of those kinds of surgeries. Especially if they're perforated, they're going to have to take out some of the gut and hopefully reattach it. And they leave as much bowel as possible. Now, we have 2 theories on what causes NEC. I think the most current one is that the baby may take a hit, what we call a hit, in labor and delivery. The mother may have had a spike in blood pressure that affected the baby. When Mother Nature builds babies, the guts are the last thing on the totem pole to be saved. The blood is rerouted in the baby's body to save the brain, the heart, the lungs, the kidneys. Those are all vital organs. The GI tract is not considered a vital organ to Mother Nature. It's very vascular, but it's not considered a vital organ. So it's the one to go first. So it could have gotten a little blood clot, a little bruise, a little dead spot from not getting blood during the mom's event, and that's where it's going to fester. And you may not know about it until after delivery and after you started putting food in the baby's belly. This is what air looks like on an x-ray. This is NEC. I told you in radiology, the gut air is black. Okay, so this is a lot of pockets of air all around here. So he's big belly, big full belly. Now it's kind of hard with these lights, but you see this white line right here? That's the outside of the abdomen. Follow it down, you can see the abdomen. There's air between the intestines and the wall of the abdomen. And that's a perforation, that's free air. So that is probably, when they go in to do surgery, that's the first place they're going to try and repair. This is what the baby might look like on the outside. Sick baby, on a ventilator, IV fluids. He's not able to breathe very well on his own. His belly is so high up that he can't pull his diaphragm down. So we have to have him on a vent to help him out. On to happier notes. Small for gestational age. These kids are wonderful. They're my favorite set. Of all the kids in NICU, these are the ones I gravitate towards. They are, if you plot out their weight on a graph, they're in that very low 10 percentile. There's 90% of the kids delivered that are bigger than them. These guys are less than 5.5 pounds. They're small. They could be term, developmentally appropriate, but they're small because mom might have been a smoker. She could have had hypertension and a very small cord and food couldn't get to the baby. She could have been a multigravida, chronic illness, lot of cardiac meds that the mom may have needed. The baby might affect the baby's size. So there's lots of reasons for it being SGA. When you look at these kids, their head is very, very large compared to the rest of their body. Their eyes are huge. They just stare right through you. They have a wasted appearance. The skin just hangs on their knees and their butt. They have no fat stores. They have a scaphoid abdomen. If they make it to term, they're usually a meconium-stained baby because they've been so stressed. You'll see a lot of meconium on them, and their cord will be a kind of a green-black from the staining of the meconium. And they have poor muscle tone and a thin cord. These are SGA kids. This is a full-term kid. Scrotum is very pendulous, so I'm going to call him term. But look how his belly is so scaphoid. There's nothing there. He was starving to death. But you can see when he's kind of turned, there's bones right there. That's his chest, bones, and he's scaphoid. The cord is kind of black-green from all the meconium. This guy here, SGA baby, low tone, big head. Look how big that head is. How big those eyes are. They're huge. Saggy skin over the elbows, shoulders, back. There's nothing there under the skin to hold him up. So he's a good example of SGA. But that kid there, they were both close to term and were starved in utero. There's a lot of physicians that follow these kids very closely by ultrasound, and if the babies don't grow, they get to a point where they aren't gaining weight, aren't growing, they will go ahead and get the baby out, either vaginally or section, to help the mom, because sometimes it's safer on the outside than on the inside. Post-maturity. These are kids born after their due date by 42 weeks, after 42 weeks gestation. They have a higher risk of injury because of their size. These kids have had 2 or 3 extra weeks to grow, maybe another 2 pounds heavier than they should have been. There's only so much room to be delivered, and they're going to have a higher risk of injury. And the placenta has an expiration date. It doesn't last forever and keep functioning. So when you get to 42, 43 weeks, you start wondering how much longer that placenta is going to last. They'll start coming apart at the edges of the wall in the uterus so that the placenta is starting to break away and decrease the amount of nutrition that the baby's getting. They have very little lanugo, it's all fallen off. Very little sub-Q fat because they've had to resort to burning their own fat to survive. They have no vernix, that's gone. Their skin is dry, cracked, they're peeling, just comes off in sheets, just peeling. They're yellow-green because of the meconium. They have long nails. They've had time to grow nice long nails, but unfortunately they've scratched themselves and they're very stained, and these are not cute kids. These kids here have a tendency to be hypoglycemic. Usually if you do the first glucose almost right away, that sugar is going to be low. We'll get these kids in NICU to just help support their sugars. Everything else seems to be okay, but they don't have any stores and they've starved to death. Not to death, but they're hungry. This is a post-mature baby. You can see the pony once again on the cord. Look at his peeling skin. It's just coming off in sheets. Here's sheets. But he's starving. Look at he's sucking on his hand. We told you kids to suck on their hand for comfort and for nutrition. But he has all this extra skin on his arm. It kind of bundles up next to his elbow. So this kid here has used a lot of his own fat to survive. Okay, infant of diabetic moms. This is on the increase. It's a more prevalent in the worldwide than any of the endocrine disorders. If you have poor metabolic control in the mom, it directly affects the baby adversely in the first couple of weeks of life. She may not even know she's pregnant. Now, when I talk about this, I immediately start picking on the teenagers because I know they're a little bit harder to get to be compliant. So let's say you have a 17-year-old who is pregnant. You guys are over 17, 18, right? Okay. Okay, so 17-year-olds are not very compliant. They know everything. All right, so they're pregnant. They may not even know it. So a diabetic teenager is even more dangerous. Okay, so she's on her way to school. She gets a little hungry. Maybe she forgot to take her insulin, so she drives through Dunkin' Donuts and gets a couple Bear Claws and one of those fancy frappes with caramel everything. And so what's going to happen to her sugar? Skyrocket. It's going to go up. What's going to happen to the baby's sugar? It's going to skyrocket. Okay. So the mom will spit out whatever little insulin she has, but it probably won't make it to the baby. The baby's pancreas isn't working well yet, so he's kind of living in this euphoric high sugar land world. So the mom goes to lunch, and let's really make her bad. She's going to go to McDonald's, and she's going to have one of those new triple-decker bacon cheeseburgers, and supersize the fry, and get a regular Coke. Oh, let's make it Mountain Dew. That way she'll spike out on caffeine. So she's having Mountain Dew today. What's going to happen to her sugar? All right. So that mom has an increased risk of having a stillborn. These kids don't tolerate this. So she has an increased risk of having spontaneous abortions. The stillborn population is very high in infant of diabetic moms who are not controlled. These kids have a higher chance of having congenital anomalies. Cardiac defects are the number one thing we look for in infants of diabetic moms. Because the baby will probably, with all the sugar that it's had to live on, it's probably going to be very, very large and cause more trauma to the baby and the mom at delivery. These guys are usually C-sections because OBs who have finally caught up with this patient and monitored this patient know that this is a nice 12-pound baby and there's no way this mom's going to deliver it. So they may take the baby out at 37, 38 weeks. So what happens is they get to be very large. Now, this baby could have been term, but I'm going to say it's not because he's in an isolette. If he was out in a crib, I'd say he has good temp control. He's in an isolette, so I'm going to say he might have gotten a little cold. So this is probably, what we do is when we have these kids, we have to go to pediatrics and get larger diapers, size 1 and size 2 kids. So we get the larger diapers from Peds. Now, because he was born prematurely at 36, 37 weeks, he may have a little bit of respiratory distress. Remember we talked about the TTN and the fluids in the lung. If you section, he didn't get the advantage of being squeezed in the vagina. He was just taken out of the uterus. So probably got a little oxygen going for TTN, a feeding tube in, because when does the sucking start? 33 to 36. So if this kid has been traumatized at 36 weeks, he may not want to eat. He's still living off his own sugars. So you have to start feeding him by tube. We're going to have high glucose IV going and feeding tube, and we follow these sugars every 3 hours to make sure that we're balancing it out. Formula has a glucose of about a D7%. These guys here, we can start IVs. If it's a central IV, we can go up to D25. Same, it's a high concentration of sugar to keep them supported. Complications are the prematurity we've talked about. If they're living in a hyperinsulinism, the insulin will block the surfactant that they need. So if the mom did take her insulin and the baby did get a lot of insulin, then it could block the surfactant that he needs to develop. And we already talked about the TTN. VSDs, ASDs are very prominent, these guys. Polycythemia, the crits are higher than 65. So we've talked about what happens when they become plethoric. Their crits are high. What do they look like? Jaundice. They look ruddy red when they cry, and we're going to watch them very closely for jaundice. So these guys here, on top of everything else, have to go in phototherapy. They could be born without a kidney or two, and they have a high risk of myelomeningocele and being an anencephalic. Now, this is a very highly litigious area of our life. Moms and dads are very, very smart. They go to Google and Google everything. As soon as she heard she was having a baby and I'm diabetic, what do I need to know? They learned that if a baby's blood sugar drops, that it might cause brain damage. So this is a very highly litigious area, and we have to document everything. So if you get a glucose less than 50, put the baby to breastfed, C-tube fed, started an IV, all those things. Because if that child cannot read in the 2nd grade, they will request his records to see what happened. They want to know how low did the sugar get and what did you do about it. So what happens, if you treat it quickly, jump on it, treat it quickly, and he doesn't have any further episodes, you've got him nice and stable, he'll do fine. He's just going to be a big kid for a while. But they do have an increased risk of the neurodevelopmental deficits. Not to be confused with just the baby. Did you have a question? No? Not to be confused with the kids that are just hypoglycemic. Not diabetic moms. These kids are just hypoglycemic. And that definition of hypoglycemia is still kind of up in the air a little bit. The doctors do not want to really set a number, because then everybody's going to stick to that very black number. If you say a glucose of 50 is good, but 49 is hypoglycemia, and this is what you need to do, the lawyers or families are going to jump on that bandwagon. So they don't really want to concrete themselves in. And this talks about the published ranges, 20 in preterm infants and less than 30 for plasma concentration. So the heel stick that we get is going to be different than what it is in the plasma. There's going to be 3 categories that you need to think about when you have a baby that's hypoglycemia. The inadequate supply. They could be just premature and not have the storage. They're infant uterine growth retardation. They're just small kids that didn't have the chance to have the buildup of fat. Placental insufficiency. Abnormal endocrine regulation. Diabetes, pancreatic lesions. We had a baby, that beautiful term baby girl that just couldn't keep her sugars up, and brought her into NICU, started central line, and she was on D25, and we still couldn't get them up. started her on medications, and a side effect is hyperglycemia, and brought in an endocrinologist from St. Joe's, and he did an ultrasound right there at the bed and discovered that the baby had a tumor on the pancreas, which was affecting her insulin. It was just spilling it out of her. Okay. Predisposing factors, we talk about big babies being premature. The mom might not be the right size for the baby, the cephalopelvic disproportion. Forceps deliveries, we don't do a whole lot of those anymore, but they've replaced it with a vacuum. The vacuum is a little suction that the doctor actually has more control over how much suction they're using based on the progress they're making. If mom's having a difficult labor, she could have been in labor for 12 hours at home and gets tired and isn't able to push anymore or have labor, she's going to poop out on you. Breech presentations are predisposing, and rotation of the fetus. If it's transverse, you want to try and move them. If not, that's a section now. Prevention is essentially just pay attention to your risk factors. Get to know your patient very well, what they're going to give you. And the good labor and delivery nurses, if they don't, before they even get the paperwork on the chart and things like that, they're already examining the baby by how big the mother measures, where the head is, that kind of thing. They want to know right away what they're getting. This is shoulder dystocia and Erb's palsy. Shoulder dystocia is the shoulder got hung up, and when they tried to manipulate the baby a little bit, the head kind of stretches this way. This nerve here kind of stretches, and it will affect this arm. Now, you can't see it on this, I have another picture of it, but the clavicle broke. This is what happens, is that the clavicles are very soft. They're actually Mother Nature's way of coming out. So that breaks to give them this shoulder dipping down and coming out. This is palsy. It stretched out that nerve, and it's going to be a dependent extremity. And what happens is they leave alone. They may put a T-shirt on the baby and pin it up like a sling. If it doesn't go away by the time they get to their first or second pediatrician appointment, they may give the baby some PT for the mom to do. Now, facial palsy is a little different. If a baby winks at you, you go into a baby's room and you think they're winking at you, they don't have that capability. This baby here has facial palsy. He's in full screen. So when you scream, don't your eyes close, both eyes? So he's screaming, this eye is closed, but this one is open. You can't close it. This eye here is a wide open cry, but this face here, this mouth here is dipped. It doesn't close or doesn't open. So that's a facial palsy. This is another example. This guy here is in a cry as well. But you can see the grimacing on this side is more natural, more normal, where this eye is still a little relaxed and open. And the mouth here, a good example of this mouth being wide open, and this is very relaxed on this side. So symmetrical movement. When you're looking at your baby, you want one side to look like the other. Picture of a fractured clavicle. The one on the right is showing you that that's what it looks like. On the left is an X-ray, and air is black. So you see it right here. There's a little break right here in this bone. And you can see this little nodge right here is what you would be feeling. It goes like that, and that's what you feel when you walk, when you touch it and palpate it. Okay, early onset sepsis. This sepsis is almost always acquired before delivery. This is exposure to mom. Primarily it's going to be GBS. This is a picture of Group B strep sepsis in chains. They're not purple normally, but they're round balls, round fuzzy balls, and they're in little chains. The purple is the dye that they use for the picture. With babies, it turns into a multi-system involvement almost right away. These kids here will give you very subtle signs of sepsis. We've talked about the little spits, the little dips in temperature, maybe a bradycardia that they weren't used to. But within 12 hours could be on a ventilator. That's sick. Because as we get older, we localize our infection. We have earaches, we have belly aches, we have an infected eye. These kids can't do that. The risk factors are prematurity, low birth weight, ruptured of membranes more than 18 hours. These kids here, we have power plans that we will follow with more frequent vital signs. If the mom's temp was up, or if we have diagnosis of an amniochoritis. It's non-specific, non-low temperature instability. We've talked about all of this. The treatment. We screen moms now at 36 weeks of age, which kind of leaves everybody that delivers before that out of the picture. So then we just hope for the best. But moms, we screen rectally and vaginally at 36 weeks of age, so we have a baseline. We know what's going on. If she comes back positive, when she comes in for labor, we give her, we hoping it's 4 hours before she delivers, but we gave her a dose of antibiotics. And hopefully that will cover the mom, cover the flora that's in her vagina, and start getting to the baby, so that the baby has a little dose. We keep close contact with the baby. They have increased vital signs. They may or may not do blood cultures, depending on how sick mom gets, but we definitely do a CBC with a differential to see if there's any shift in any of the numbers to say that the baby might be getting sick. If the baby shows any signs of anything, either the shift in the CBC or a drop in the temp or spits, we bring them to NICU and we start antibiotics right away. We don't wait. The kid has respiratory distress. We're going to do a chest x-ray, and I'll show you one. And we don't do a lot of LPs anymore. We used to do them on everybody, but they've never really panned out. We've learned that they never showed us what we thought they should. Okay, this is GBS sepsis. This baby here is 5 hours of age, and this is a chest x-ray of GBS pneumonia. So you can tell it's not black hair like it should be. It looks more like cotton balls. It's real fuzzy. So that's a pneumonia type infection. This little girl here, a little bit older in pediatrics, she was able to localize the infection that she got around her umbilical stump. So she grew out GBS and was in pediatrics for a week for antibiotics. Now, late onset sepsis is nosocomial. That's what we give them, or families, mothers, not just us. Everybody's involved. So this is where you do a lot of your parent education, and you teach them hand washing. If they're smokers, you have them put on clean, a gown so that baby's not exposed to it. You want them to wash their hands frequently, that kind of thing. The most common organisms are E. coli, GBS, Klebsiella. The risk factors are the same. Invasive procedures, though, if you think about it, if the baby came to us and hypoglycemia, and we took us, because he's such a big kid, we had several attempts to get an IV in him. So it took us 3 or 4 attempts. That's introducing, as careful as we are with our CHG and stuff like that, we were invading the baby's skin. We were breaking skin. So if he came down with an infection, we would start looking at our sites to see what they looked like. Signs and symptoms are the same, and the treatment is complete set of blood cultures, more labs, and 2 different kinds of antibiotics. We usually use ampicillin and gentamicin. Prevention is hand washing, everybody, all the time. Use of gloves when in contact with the body fluids, screening of parents, siblings, and visitors. If they even look like they have a cold, fever, runny nose, anything, we try to keep them out. We screen team members. I have no problems telling one of my peers to get the heck out. Or go wash your hands. You didn't do that. You forgot to wash your hands. I saw you come in, go wash your hands. And no sharing of equipment. That used to be the thing, is that everybody would have their own stethoscope. And we'd go from baby to baby to baby doing our assessments. I mean, my mother gave me a Littmann neonatal stethoscope when I graduated. And it's kind of like it's hanging in my closet because we can't share it, and what's it going to do for me? So, but no sharing. Everybody gets their own. Neonatal abstinence syndrome. We're not seeing a lot of these kids anymore in the NICU. We're seeing them more in the mother-baby area. So when you're in the mother-baby areas, you can ask them about them. But it's still out there. I looked it up online, and Pinellas County and Hillsborough County are still very high with drug abuse and moms and babies that are NAS. Unfortunately, any of the research that we're trying to do on these kids, they've made it so strict as far as what kind of drugs and stuff like that. We can't find any moms that are just on methadone. Very few moms are just on methadone, so we could research with them. They're on methadone, but they're also on other things. So it kind of follows up our research. So the big takeaway with this is that to remember that to watch your own biases. If you have difficulty working with mothers that have become addicted for reasons of their own, then you need to check it at the door. Just like if it was a cardiac disease, you wouldn't deny them care, would you? Okay. The biggest thing I learned from one of our social workers is that these moms did not get pregnant and then say, I think I'm going to go out and do drugs today because I got pregnant, I want to party. You know, I'm a new drug person, I'm going to go out and see what it's like. They don't do that. They're dependent on these drugs, they're addicted to these drugs, whatever their choice is, and then they got pregnant. So now they're dealing with both. So if they're lucky and they're smart, they go to Operation PAR, so at least they get some kind of prenatal care and some kind of following. Education is very good for these ladies. I did classes for Operation PAR at Countryside, and I always felt that if we could teach them beforehand what to expect. The addicted person doesn't like surprises. They like routine. They like to, if you tell them you're going to do something, you have to do it. So what I would do is bring them to Countryside, give them a tour of the unit, introduce them to nurses, so that when they came in, or if they came in, they'd at least have somebody that they recognized. It wouldn't be a total stranger. We would go over what to expect during delivery, take them to show them a room, go over the Finnegan scoring, go over therapeutic handling techniques. They would bring dolls, and if not, I had dolls, and we'd practice swaddling and seat positions, and they would know about morphine and how to score a baby. In the very beginning of time, I had pediatricians calling me wanting information on therapeutic handling and Finnegan scoring, because I would tell my moms that after discharge, if you get out of here in 5 days, like we're hoping, if your baby starts having higher scores at 12 days, I want you to call your pediatrician, and I want you to tell them, my baby has a Finnegan score of 12, I need help now. I had pediatricians calling me not knowing what to do with these kids. Or what does she mean she has a kid with 12? So it's kind of like we had to teach the community, and they're much better at it now. The extent and onset of withdrawal when you get out to mother and baby depends on when the mother last got her last dose. It is also depends on how much the mother metabolizes the drug. We've had kids come in and have absolutely negative urine drug screens, negative cord screens. The mother was on methadone, but the baby didn't have any. So the mother metabolizes. You start watching these kids at about 24 hours. Some of the first symptoms you might see are very subtle ones. They might be a little bit more irritable or not sleeping a lot. These kids don't sleep. They just wake up and start wanting to eat again. High tone, when you change their diaper and you lift their legs up, their whole body will come up. Or if you do the test for tone, you know how when you lay the baby on the bed and you lift their arms up, they're supposed to get a good head lag. It just drops way back. These kids, their heads will come up with their bodies. None of that is life-threatening, and the kid will do fine. But when they get to the point where their symptoms are interfering with their survival as an infant, that's when we have to step in. Excuse me. They may need morphine for discomfort, and that's when they come to us. They get scores of 8, 2 or 3 times, double checked by nurses, and then a practitioner goes out and checks, talks to the mom, and the kid's admitted to us, and we start turning down the lights, doing a lot of swaddling, doing skin to skin with mom, and we may start low doses of morphine just to get that baby under 8. As the baby is withdrawing from this medication, her scores will go up and will go up in the morphine. Now, we have clonidine, which is our second line drug, and that works on the GI tract, but we use special formulas. There's a low gas formula out there. You can probably buy it in the market now, and that helps with the gas production because they scream a lot and just build up a lot. So it's a very challenging group, but it's just one that we got into in about 2008, 2009, seeing less of it, but I don't know where they're going. They're not coming to us like they used to. We do use a Finnegan scoring tool. Look at it when you're at the hospital and try to score a baby. Score a normal baby, an unexposed baby, because a normal baby, unexposed to drugs, is going to have a Finnegan score of 4 to 5. Newborn babies don't sleep 3 hours. So if they only sleep 2 hours, that's already a point. So it's kind of like they may wake up and be a little fussy. They may, have a little yawn or sneezing or something. Those are all signs, and you give them points. So try doing a normal baby or unexposed baby and see what you get. Now, therapeutic handling techniques are nothing that I developed. There was a gentleman physician, and I wish I could remember his name to give him credit, but it's on, if you Google it, it's the funniest or the fussiest baby on the block. Does anybody know the book, Fussiest Baby on the Block? But I took it straight out of there. You can buy it. It's a parenting handbook. It's been around for years. So these are all tried and true things that my great-grandmother probably taught my grandmother, but my mother moved away and didn't get the opportunity to learn it from her mother. So then when I had kids, she didn't teach me. She didn't know about it. So we all now encourage parenting classes. Nuclear families, we don't do those anymore. So we're not learning from other people's experience. So these are all things that our great-grandparents knew about, but it's the swaddling, the wrapping of the baby, the pacifiers, the fingers, gloved fingers in the mouth, the rocking, the swaying. You can always tell new moms in the grocery store because they got a bag of bread or a 5-pound bag of potatoes, and they're going like this. They're rocking, right? You've seen them? People can't sit still because they want to rock. It's the natural motion of the world. C position, that's where you draw their knees up to their abdomen a little bit and tuck their heads in. It decreases a lot of the tension in their central core. You want to feed them small feedings frequently, every 3 hours until they get over the most of this, and then they can go to every 4 to 5. The big thing is decrease in stimulation. Low voices. Cigarette smoke is toxic to them. They can't stand the smell of cigarette smoke. So we encourage parents don't smoke, and that's when we tell them to put on patient gowns if they come in. Grandmas and grandpas have a tendency to walk into the room and be very, very loud. So if you're trying to decrease the stimulation in the room, you can encourage the parents to put a sign on the door, shush, baby sleeping, to kind of give people the heads up, be quiet when you enter, or just tell them to go away, do not disturb, that kind of thing. Check at the nurse's station is always a good one too. We talked about that. Right now, this 4 to 6 weeks is now down to, most of us are averaging 20 to 21 days to getting the kids from admission to discharge. So we've done very, very well in our education of the nursing team on scoring, so they're more consistent, and teaching families how to come in. We need them there at the bedside so that they can directly and immediately take responsibility for their baby's crying. If the baby's crying, we want somebody to intervene. If the nurse who has that baby is admitting a baby or coding a baby over there, that kid might lay there for a little bit until somebody can get to them. So we're encouraging families to be there. Okay, this is swaddling. This is a fussy baby. You can see by the action of the hands and the mouth. Families in crisis, and this is every family, not just the NAS kids. When you have a family whose baby comes to NICU, these guys here are in crisis. They have anticipatory grieving. It's not what they wanted, not what they planned for. Their birth plan is gone. They may withdraw from relationships. If they had a solid marriage beforehand, that might be a little shakier now with the baby in the NICU, because there's turmoil as to who's cooking dinner, who's picking up Johnny at soccer practice. You want that kid to be normal, but you still got a baby in the hospital. You have to acknowledge the family's feeling of guilt and failure. They thought they were doing everything right. It is nobody's fault. It just happened. You want them to resume relationships quickly. You want them to go out to lunch with their friends, especially if you have little kids in the nursery that are going to be there for a while. You want them to resume relationships. That's their support system. They need to get out and start feeling normal. We have moms that give up their maternity leave and go back to work so that they can return to maternity leave when the baby gets discharged. So they're normalizing their life as fast as they can so that it will be normal at a later date. We prepare them to take the baby home, of course. Now, these moms and dads should be followed very closely for postpartum depression. Have you guys seen the video yet on postpartum depression? No, not yet. Maybe it's in your future. But postpartum depression and PTSD, dads especially, they will go through a PTSD. Might not be anytime soon because they got a lot on their plate to accomplish. But when things calm down, they may break down. So you have to constantly keep up with that dad. How's it going? What's going on? Did you go back to work yet? That kind of thing. And they will open up eventually. They're just not as easy to open up as mothers. I mean, we'll talk about everybody, right? But the dads don't. The big thing is they have to adapt to intensive care environment. You were in intensive care. What was your struggle?
You don't get enough time. There's only certain hours you can be there, and they.
Oh, see, so we've adapted. Good. So in 11 years, because she shared her story with me, in the 11 years since she was in the NICU, we have open visitation. A mom can sleep at the bedside, and we offer them blankets, that kind of thing. There's some units that have little cots. We have reclining chairs that you can sleep in. We prefer that you not do that on a daily basis. We'd like you to go home, rest in your bed, because you do get grumpy. You have to help the parents become aware and acknowledge their feelings. So we all cry very easily. They cry they laugh, we laugh. We've had brisses, we've had birthday parties. At Valentine's Day, we send Valentines to the families from the babies, hang them on the walls, that kind of thing. So, and we encourage the parents to decorate their rooms. You know, we can't have Mylar balloons because of the gases, but they come in and they decorate the bulletin boards and stuff. So we ask them to be involved with us. Open, honest communication. We are starting a campaign at the hospital, and you'll probably hear about it if you're working in our area. It's called Commit to Sit. So we are no longer going, what's your name? Jonah? Jonah. Okay, so we're not going to go to Jonah. Jonah, how you doing? God, I'm glad you're feeling better. Thanks a lot for being here. What kind of customer service is that? We're going to commit to sit. So we're going to sit down next to Jonah so that we can make eye contact. And that's what we're trying to do in the NICU. Getting neonatologists to stop for a minute and sit down and talk to their patients. Jonah, how you doing? Did you go back to work yet?
No, because I'm in school.
Oh, come on. Jonah, how's your baby?
Really good.
Good, thanks. Okay, you're not very good at improv either, are you?
Yeah. I was trying to be really tough.
Okay, so but see the difference? If you sit down, you take a minute, it shows them that they are important. So they're important to us. So that's what we're doing. Appreciate the psychosocial functions in the family. It may not be the mom and the dad that are the primary caretakers. In a lot of cultures, it's the grandparents. So if you see a grandma kind of taking control, you might want to talk to mom and see on a one-to-one sit down. Is this okay? Is this what you want? That kind of thing. So if the mom is being robbed of time with her baby, try to come up with a game plan on maybe mom should come alone for a while, a couple times. Let's see, flexible unit policies. We're real good with siblings, support systems, interactions. We have parents, we're getting a video system now, we're working on that, to get a Skyping system type thing where it's an iPad that sits on a frame over the baby's bed where a mother can call in and we can turn the baby on and she can sit there and actually watch her baby for a while. So that's where we're heading. We're hoping for that soon. And we've talked about postpartum depression. Any questions? Okay, no questions at all. You guys are good. You can come take my job. I'm done. All right. Thank you so much for allowing me to come visit with you today.
Thank you.
Thank you.